This is the keynote lecture, and it gives me great pleasure to introduce our chairpersons. Dr. Purish Parikh, who is the president of Asia Pacific Cardio-Oncology Society, and Dr. Vivek Agarwala, who is the honorary secretary of Asia Pacific Cardio-Oncology Society. So I welcome our chairpersons, and I request you to please introduce our keynote speaker.
It gives me great pleasure to introduce Dr. Arjun Ghosh to all of you. Dr. Arjun Ghosh is a consultant cardiologist at Bird's Heart Center with the University College of London Hospital and associate professor. He is one of the first cardiologists in UK to be appointed specifically in cardio-oncology, one of the pioneers in cardio-oncology in UK as well as in Europe. He has, changed and is involved in developing cardio-oncology curricula and guidelines. He published the first British cardio-oncology guidelines in 2021, as well as the national late effect guidelines from the BSc. He runs the UK's only national cardio-oncology study day and helped organize the first pan-European cardio-oncology symposium. Cardiac MRI and cardio-oncology echocardiography is one of his special interests, and he's taking many leadership and management positions in British Cardiovascular Society, British Cardio-Oncology Society, ICOS, and even he's associated as one of our lead advisors at Asian Cardio-Oncology Society. He's the co-host of the ICOS podcast, and he has been appointed to the ACC Cardio-Oncology Leadership Council. He was awarded the top-level National Clinical Impact Award from NHS in 2025 in recognition of his outstanding contribution to UK medicine. So, ladies and gentlemen, Dr. Arjun Ghosh, our keynote speaker.
Thank you very much, Vivek, for that kind introduction, and I'd like to thank also Dr. Parikh for the invitation today. So I'll be talking about big data, emerging technologies in cardio-oncology, and I think we've had a lot of talk about AI, so hopefully I will not give too much of an AI overdose. It's always nice to be back in Kolkata, the town of my birth, where I did my medical schooling, so always nice to be back. Those are my disclosures. So I'll be talking about big data. What is big data? I'll be talking about why is it relevant to cardio-oncology. I'll be talking about what resources we have, what's happening in this space, what are the new ideas in this space, what are the emerging technologies in this area, and how we can bring cardiology and oncology together. And I'll also be talking about how best can we use them in the cardio-oncology space. So, what is big data? This is one of the main questions that we often get asked, and this is a very nice pictorial representation of what people think big data is. So you can see the common themes: volume, storage, precision, and also here in the corner, difficult. I think a lot of us, when we've been talking about big data, AI, we've been thinking that this is maybe something difficult. So should that be the case? So, in the commonest way, when we look at it from the medical point of view, big data is a way to harness big data sets to try and answer some meaningful questions. And in terms of big data, we have registry data, we have electronic health records, and RCTs at the moment, obviously from a prospective point of view, is not the way that we can harness big data, but maybe in the future. So at the moment, very much it's being used in a retrospective manner and looking at real world evidence as well. And going forwards, maybe we can harness it from the prospective or the RCT viewpoint. So when we talk about large databases, let me give two examples, two studies. So the SEER Medicare database. This is an American database, and it links the SEER along with the Medicare. And we have two combinations of things. So the SEER is the Surveillance, Epidemiology, and End Results Program for Cancer Registry. So very much a cancer-focused cancer database. And then you have the Medicare database, which is a database looking at claims, insurance claims in America. So the first study that I'd like to highlight is a study by a good friend and colleague of mine, Dr. Ovidio Guho, and he and his group looked at atrial fibrillation and breast cancer. So what they wanted to see was, in America, what is the incidence of atrial fibrillation in breast cancer patients? And using the Sears database, they basically divided patients into breast cancer and a matched cohort without breast cancer. And they followed these up for a 1-year period. And what they found was, in over 85,000 patients, the incidence of new onset atrial fibrillation was around 4% in those patients who had breast cancer. Now, they matched it, as I mentioned, and in the matched cohort, the incidence of atrial fibrillation was only 1.8%, so nearly half the incidence of atrial fibrillation in those without breast cancer. Apart from the traditional risk factors, it was also found that the stage of breast cancer influenced whether the patient was going to develop atrial fibrillation or not. Now, another large database is the FAERS database, the FDA Adverse Events Reporting System. And this is a database run by the Food and Drug Administration Authority in America, where any consumable, oral consumable, including medications, you're meant to record the adverse effects. And millions of adverse events here. So again, a study where Avi Guho, myself, Claire Roddy, and other colleagues from around the world looked at the adverse events in the FAERS database for CAR-T therapy. So this paper was from a few years ago, and at that time CAR-T was really an emerging therapy used in some centers as a trial therapy and in some centers used in clinical practice. And what we found was that there was a quite high adverse event rate, 20%, and of the adverse event rate, the 20% was of cardiovascular adverse event rates. And those patients who had cardiovascular adverse events rates actually had quite a significant morbidity and mortality from the cardiovascular side. And arrhythmias were the commonest, but alongside that you also had heart failure, you had heart attack, and it was often associated with ICANS, which is a kind of overlap with neurological toxicity as well. And this is a single linkage hierarchical clustering model, which just kind of illustrates the point that I've made. Apologies if it doesn't project so well. Now, I've talked a lot about the databases in terms of the registry data, but we also, of course, have electronic health records. And in the UK, two of the large electronic health records are EPIC and Cerner. Of course, there are many, many types of electronic health records in many countries. And this is a study by my friend Vlad Zaha in Texas, where he looked at his electronic health records to see if he could, in a real time, understand when the patients were coming into the cardio-oncology clinic or being seen on the cardio-oncology consults, whether we could get some data in terms of how long they were having to wait, what were the wait times for blood tests, what were the wait times for echocardiography, for MRI, etc. And what he found was that using his electronic health records, if it was utilized in the correct way, it gave a very good understanding of what were the bottlenecks in treatment in terms of time-specific bottlenecks. So this is something that we all have access to in terms of our own health record system. Coming on to the registries, and I think that Aruni mentioned this, the Global Cardio-Oncology Registry. This is, again, a multi-center global initiative. And there are a number of goals which have been achieved, and there are a number of potential goals. And the aim of the Global Cardio-Oncology Registry is really to understand the practice both in hemato-oncology, and also in medical clinical oncology, in terms of phenotyping what are the risk factors for these patients, and what is the influence that those risk factors have in terms of treatment and in terms of outcomes. But on the right-hand side is really what we should be doing, and this is again where the big data, the AI concept comes in. So as you can see, the big data side is really talking about automating this registry data. We're also talking about integrating it internationally. We're also talking about linking it to other registries, and then the imaging and the biobank. So as you can well understand, we are talking about hundreds of thousands of patients, all of their data. We have to have a larger big data AI mindset to look at these data sets. And when it comes to emerging technologies, this is another group that I'm involved with, which is the COIN group. And what is the COIN approach? So the COIN approach really has a number of different facets to it when we're looking at emerging technologies. You have the collaboration angle, you have the innovation angle, and then you have the education angle. And this really came about really with COVID. COVID was the push for this digital health, telemedicine, really showing how we should be harnessing different approaches to try and take the treatment to the patient, not bring the patient to us for treatment. So this is the COIN approach. And we've been talking about AI and imaging and machine learning, and different studies have been mentioned. And I just wanted to highlight this study. And very, very nice study looking at a different approach to try and identify which are the higher risk patients, which are the patients which will develop cardiotoxicity. And what this group did was they used a number of different types of AI modeling. They used deep learning, artificial neural networks. They used the random forest method. I think all of these have been touched upon in previous talks, just to see if this was able to predict whether cardiotoxicity would happen in their patients. They then adjudicated this with a multidisciplinary board, and I know that there will be talks by Arjun on the Cardio-Oncology MDT. So this is again an example of how AI can be used in the Cardio-Oncology MDT setting to try and get a better outcome for our patients. And what about cardio-oncology, AI and cardio-oncology imaging? So this is a chapter that we wrote on AI imaging and cardio-oncology, which came out this year. And what were the key points from this chapter? What were the interesting points? So AI is a tool. It's a helper. It's definitely not a replacement. It can help with diagnostic accuracy. So we've talked a lot about repeat echocardiography for surveillance. Echocardiography has maybe 5 to 10% intra-observer variability. AI can definitely try and decrease that. We've seen that. It won't necessarily get to CMR levels of reproducibility, but it can improve, especially with 3D. And we've really been talking about personalized medicine. So one place where oncologists are far ahead of cardiologists is precision medicine. Oncologists will be doing, genotyping, phenotyping. They'll be doing analytical data to try and give the patient the optimal treatment for the cancer, using all of these different techniques and tests. We are far, far, far from that from the cardiology perspective. However, using AI maybe can help us get there. Increased efficiency. So this is also, of course, important. So the time it takes to contour when we're doing a cardiac MRI scan, the time it takes to contour when we're doing a 3D echocardiogram, all of these can be improved using AI models. And then hopefully this will lead, of course, to improved patient outcomes. And if we focus, specifically on cardio-oncology echo, so this was another one of the chapters that we wrote. And then, this is an example of how AI can help just in a general cardiology patient. Image acquisition, it can help in view identification, it can help in segmentation, it can help in GLS interpretation, also in focusing and understanding the GLS, getting the data much more quickly. I think, in GE, Philips, all the systems, TomTech, all of them produce an AI model very fast now. And if we then take that to the cardio-oncology space, again, automated analysis using the GLS, all of this, of course, is integral to diagnosing cardiotoxicity at an earlier stage. So AI very much has a role to play in cardio-oncology imaging, specifically in echocardiography imaging. And we've been talking again about precision medicine, personal medicine, and this is something that Diego Sadler and colleagues very, very nicely highlighted. And if you look at stage 1, this is kind of where we are at the moment. We're talking about traditional data. So, health records, looking at their, blood pressure, what medication are they on. So this is the first stage. Where do we take it to the second stage? We then take it to the phenotyping stage. And as you can see, in the phenotyping stage, we really are then talking in more detail about demographics, about the omics. We're talking about the electronic health record integration. That then takes us to the third stage, which is really, where we want to get to, the precision medicine stage. Here, we are integrating all the things that we've talked about, the big data sets, the AI, to produce a precision model treatment plan for an individual patient. And that's really, where we want to get to. But there are a lot of gaps in this area. So these are the things that maybe that we have been doing, but those are the gaps on the right-hand side. So we still we have very heterogeneous data. We don't have homogeneous data. Capturing the data sets, making sure the data sets are viable for clinical use, viable for analysis is a very big challenge. Having demographic data, identifying where the issues are with socioeconomic data, identifying the issues with racial data depending on different countries is extremely challenging. Funding these different data sets, trying to understand and what is the government interested in when it produces funding for different initiatives. So policy change at a governmental level is also required, which is extremely important from the lobbying side. So lot of gaps that we need to make up in this area. So in conclusion, at the moment, I think that maybe the AI, big data, we have moved a little bit away from this. So this is the Wild West. Maybe we're a little bit away from that. We're moving a little bit more to the right side, the future. But I think that, hopefully conferences like this, talks like the ones that we've had today will inspire us to consider more about the big data side. And just of interest, we're launching a new journal, the Journal of Cardio-Oncology. So Susan Dent, I think, is speaking next, is the co-editor, and Mike Fradley and myself are also there. So if people are interested, please consider publishing there. Thank you very much for your time, and thank you for listening.
If there are any questions from the audience, then we can take 1 or 2 questions.
It's a keynote address, no questions.
That is the prerogative of the organizer. Yeah, please, sir.
The registries. In my experience, what I have seen, these registries help us answer real-world data more than the new burning questions. Your take of registries, ever since I have started in oncology, I always felt that meta-analysis is the father of everything. But slowly now with the new molecules emerging, I feel it is a RCT which is done a better way, is in fact better than a meta-analysis where the last 2 years RCT is far different conceptually compared to 10 years RCT. And that's where the lack of all these registries come. Censoring biases is not addressed at all. Your comment on that?
Yeah, no, absolutely, and I think I addressed that. So the disadvantage, of course, of the big data approach is that the big data is being used from data sets, which by definition is retrospective data. So if we want to take it to the stage of using an RCT, then the only way that would work is if we identify this is the question, and designing an RCT at such a large level, international level, is the only answer. Now, in cardiology, we do that. So, we have patients in prospective RCTs with tens of thousands of patients. But that is definitely quite challenging. But at the moment, this is the situation.
So I think we'll conclude the keynote session and kindly bring the plaque so that we can felicitate our keynote speaker, Dr. Arjun.